I'd like to let you know that Aussie MedEd is sponsored by Heidi Health, who provide Heidi AI transcription platform. The team at Heidi have told me that Heidi is the AI scribe built in Australia and trusted in nearly 2 million consults every week. The Heidi team have told me that students and trainees get free access to Heidi Pro, which they believe will aid quicker, smarter notes, allowing more time for patients, learning and rest. To learn more about the Pro account, visit heidihealth.com/pod. Every day, millions of Australians go about tasks so ordinary we barely notice them, from preparing breakfast to tapping on a keyboard. But for patients recovering from an illness or injury that affects the use of the hand, even the simplest task can suddenly feel impossible. Today on Aussie MedEd, we're exploring the world of hand therapy and the profession of occupational therapy, the profession dedicated to restoring meaningful daily function, and how this work becomes even more specialised when we zoom in on the hand, one of the most intricate tools of the human body. G'day and welcome to Aussie MedEd, the Aussie-style medical podcast, a pragmatic and relaxed medical podcast designed for medical students and general practitioners, where we explore relevant and practical medical topics with expert specialists. Hosted by myself, Gavin Nyman, an orthopaedic surgeon, this podcast provides insightful discussions to enhance your clinical knowledge without unnecessary jargon. I'd like to start the podcast by acknowledging the Kaurna people as the traditional custodians of the land on which this podcast is produced. I'd like to pay my respects to elders both past, present and emerging, and recognising their ongoing connection to land, waters and culture. I'd like to remind you that all the information presented today is just one opinion, and there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live. Joining us today is Charlotte Nash, an experienced occupational therapist and accredited hand therapist, and the proprietor of Full Circle Hand Therapy. She has dedicated her career to upper limb rehabilitation, guiding patients through recovery from injury, surgery and chronic conditions affecting the hand, wrist and elbow. Through Full Circle Hand Therapy, Charlotte leads a multidisciplinary team that works closely with GPs, surgeons and other allied health professionals to deliver evidence-based, patient-centred rehabilitation. It's great to have Charlotte on Aussie MedEd today. Part of full disclosure, one of the locations of Full Circle Hand Therapy is in my rooms here in Glenelg, and as such, we often work in collaboration caring for patients. Welcome, Charlotte. Thanks very much for coming on Aussie MedEd.
Lovely to be here. Thank you for inviting me.
I thought I'd start off, Charlotte, by really asking you to describe what actually is occupational therapy. Perhaps from a patient's perspective, a medical student's perspective, what does it involve and how will they encounter you in day-to-day life?
In day-to-day life, in a general OT sense, you usually see an OT in a hospital setting or be referred once you're starting to move through that rehabilitation process. I describe as OTs as the person in your life when you've had anything that impacts how you were previously functioning in your life, and we help you create essentially a ladder to get over the wall that is the thing that disrupted your life. So that could be anything from a mental health issue, it could be a spinal injury, it could be a brain injury, it could be just dealing with that transition as we age through life. In children, it can be some sort of diagnosis that may be preventing that child getting the best out of their life in their future. And OTs will look at how that person maybe previously functioned or that family or community functioned around that person and try to find tools to create a scaffold to help you over the mountain that might be the incident you've had in your life, whether that's a physical, emotional or a neurological type injury. And obviously for me in our space that we work in, we're often dealing with the physical side of an injury. However, it's incredible how much we have to engage that person psychologically to get them back into their best function in life.
So there's a real holistic approach to assessing and real function-based approach, is
We really do, and that's why a lot of our sessions, I always tell patients I'm very nosy, I ask lots of questions and it all sounds just like I'm just being distracting and everything, but what I'm really trying to ascertain is what makes this person tick and how am I going to get that person engaged in rehab to then get them the best outcomes and get them back into their life with as few complications as possible.
So really that's the core philosophy behind occupational therapy. And how does it really work in real practice? Perhaps when a patient comes along to see you, what does an assessment involve?
Really, we're looking at how we're trying to understand the trauma they've had from a medical perspective. Again, in my role, we're dealing with physical injuries, and we're trying to assess how to best engage that person in the rehabilitation process, whether they're a young 20-year-old football player or they're more elderly and looking at trying to get back into their sort of hobbies in retirement. We're trying to pick, do they have children at home? Do they have a dog they like to take out running? We're trying to get an assessment of who the person is and how they function in their world. Where the big sort of things that maybe we're going to have to slow them down a bit. So if they've just had a distal radius ORIF, we're not going to be really letting them back on to play football for the next few weeks, and how to give that information carefully, but also looking at, in that time frame, what can they be doing to get back to that goal as quickly as possible. So we're trying to find the really small parts of any task that we can let them do to make sure they feel like they're getting back into things as quickly as possible, as opposed to the old adage of pop it in a sling and don't use it for 6 weeks or something like that. We're looking at, even if it's something tiny, like they can play a little bit, and sometimes parents don't always like me with the younger ones. I say, actually, a bit of rehab with using your hand and playing some computer games is actually not the worst thing in the world, because at least we're doing something engaging.
Yeah. Obviously, any injury can take a long time to recover from.
Yes.
And you can't just wait for that to recover before you start.
We'll start as early as medically viable for that person. And for some injuries, that could be the 4 days post-op. For some people, we give more like 10 days post-op. But we are trying to find even the smallest little hook of engagement and rehab that we can at the earliest possible opportunity.
Now, certainly you guys fit under the allied health profession.
Yes.
Of which probably the average listener will know the physiotherapist is probably the most known allied health professional. How do you differ from physiotherapy?
In a basic OT and physio stance, sort of when you're looking at those general cohorts of allied health, I find that physio is very much about getting the muscle and the joint moving in a controlled setting. So you might be post-hip surgery, and we're looking at specifically getting certain goals of range of motion in a controlled environment. So that might be in the hospital, on the ward, in the physio gym. Once we're starting to look at occupational therapy getting involved, we're looking at what's the home environment we're trying to get that person home to. Do we need a different height chair? Do we need some help getting in and out of bed? And we're looking at how we're combining what the physio is achieving with getting increased range of motion and increased strength. And we're looking at how we're going to put that into the home situation or into the community driving, all those sorts of different things. And we're also looking at how are they going to engage in exercises as well. Like, how are we going to get this medical environment where we've got someone pushing you 3-4 times a day, someone to be there. The patient has to take that on themselves, and they have to go from patient to client and take control of their own rehabilitation process and put them back in the driving seat.
Brilliant.
In hand therapy, a little bit different as a subspecialty of occupational therapy, because you can be a physio or an OT to subspecialise into hand therapy. And at that point, once we have our accreditation as a hand therapist, we're performing a very similar role. Like, I would interchange in and out with a physiotherapy quite easily. We're doing the same exercises, same splinting. The physios, I find, tend to get a lot of their training when they're going through their accreditation process is sometimes looking more at what those OT skills are and how we get that engagement. And the OTs doing the accreditation process have to really drill down on their anatomy and their exercises and becoming, so we fill the gaps of each other in the hand therapy space to come together as an accredited hand therapist. And I'd say we're very interchangeable in that subspecialty. But yeah, in the community, you'll see that we've got slightly different roles.
Sure. So that obviously brings me into the idea that occupational therapy is a university degree you obtain.
Yes.
Does it vary between different countries, and how many years would have been involved?
Yeah, so it's generally a 4-year degree, similar to physio in that regards, because I think both physio and OT have got that prac component. So essentially in both of those degrees is essentially a year of that degree is prac. So we're out in the community learning those different roles. We have an international World Occupational Therapy Foundation, which is the accrediting board for all OT degrees. So anywhere that is accredited has to meet certain standards for the OT degree to be recognised as an OT degree, or it doesn't get accreditation. So we have our different registration boards in different countries. However, they have to be an accredited degree. You can't just create an OT degree without that international accreditation.
Brilliant. And then obviously different subspecialties. You mentioned hand therapy, which is your area.
Yeah.
How many other main subspecialties are there for occupational therapy?
The ones I would think of off the top of my head, obviously pediatrics is a huge area. Then we've got geriatrics, so at each end of the age spectrum. Then you would have things like prescription wheelchair fitting, vision OTs, people who deal specifically with people with vision issues, low vision. Driving is a big one. So there is a whole group that is just on competent to drive and those driving assessors. Yeah. We would then have neuro, burns. Burns is a little bit hand therapy as well. Acquired brain injuries. Then we would have community OTs, and home modifications is another. And I'm talking more complex home modifications. We're all able to put a grab bar in, but I'm talking a full bathroom renovation, hoists, that complex home modifications.
Occupational therapists fit into occupational assessments as well, following a work cover injury, for instance?
Yes, occupational rehabilitation. That's actually where I started, was in that occupational rehabilitation space where you're trying to understand a whole range of different types of employment and what effect that has on the body and how different injuries will require a different pathway to get that person back to that working space.
I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au. You've headed down the pathway of hand therapy. How much further training does that involve?
It's probably one of the more involved ones. We, in Australia, UK, US, Europe, you have a sub-speciality board. So in Australia, it's called the Australian Hand Therapy Association. And essentially it takes 2 years worth of training, which you can spread out over 5, but once you hit 5 years, you have to start redoing courses to become an accredited hand therapist. So you can join as an associate member so long as you've got sort of 12 months experience, and you usually need a letter from an accredited hand therapist to say, yes, this person is good to join our association. And then once you're on that associate pathway, you're generally participating in that accreditation journey, which requires you must do certain accredited courses. So again, the AHTA has run through and created ISO accredited courses to meet certain standards. There's 4 foundation courses. Then we have to do electives, and you have to do so many hours of mentoring and practical experience within just hand therapy. So only the hours that you do which are hand therapy related count to that. And once you've ticked those things off, then you complete that accreditation process. In America, they have what's called the Certified Hand Therapist Exam, which is a 4-hour exam, and you have to have done so many hours practical to be able to sit that exam, and that's made up part of my accreditation pathway with the Australian Hand Therapy Association.
Excellent. And what took you down that path? Why did you decide to head down the path of hand therapy?
I can remember, and when I applied to do occupational therapy, like probably a lot of people, didn't really understand 100% of what was involved in the degree. And I can remember studying this degree going, this is good, but I hadn't quite found what made me tick. And then we started our semester in hand therapy and splinting. And I can remember coming out of my first anatomy lecture, and it was like the moment I went, this is amazing. This is what I want to do. I loved my anatomy labs. I love human biology and biochemistry. And then it all coalesced into that first lecture on hand therapy, and I was like, that's my pathway.
So what are the main conditions you might see as a hand therapist? I know there's a large number. What are the main ones you come across?
We would see, so I tend to break them into what we would look at as a conservative group of injuries where we're trying to manage people and avoid having to go down that surgical pathway, and that would be a lot of tendinopathies, overuse injuries, anything that has a high inflammation background, like we're managing an inflammatory response. To arthritises, again, just trying to help people manage pain and discomfort. And then we've got our post-operative type conditions. Some of those are like if you've got carpal tunnel, we might do a bit conservatively to see if we can help that person, and then they might be a post-operative carpal tunnel as well. Lots of orthopedic things like the wrist fractures, distal radius wrist fractures, phalangeal fractures, metacarpal fractures, issues with the carpal bones, ligamentous repairs and stabilizations, again, post-operatively. Then we would have looking into different soft tissues, things like flexor tendon repairs, extensor tendon repairs, graft skin issues, flaps, things like that.
Brilliant.
So, yes, we do tend to look at things conservative or post-operative, and we have different ways of managing those different pathways. So de Quervain's is quite common pre and post. We've got tennis elbow, golfer's elbow, less common. The neuropathies, median nerve, radial nerve, ulnar nerve, trying to help people manage those sorts of things. And these could be caused by cumulative type build-up or trauma, or they could be caused acutely by an incident, depending on.
What about things like post-stroke recovery? Are you involved in that as well?
Yes, definitely, because you'll get that hemiplegic effect. We would obviously be focused on the upper quadrant. Same with like cerebral palsy, anything like that, where you've got loss of function in that upper quadrant. In our background, obviously in hand therapy, we're obviously focused here, but then in the broader space of someone who has had a stroke, it would be looking at that whole person and how that whole person as an OT assists that person getting their function back and goes back into that home environment post-rehab.
One of the more common things I see that usually I think would be better being seen straight off with a hand therapist be something like a proximal interphalangeal joint injury. Are there other conditions too that you might see that a GP could really refer straight off to you first?
Certainly tennis elbow is one, because we would like to try a lot of conservative measures with that prior to any sort of surgical intervention. De Quervain's, again, that's another good one. If we catch things early and we've got a window where we're not getting into quite an entrenched pattern of injury, then the De Quervain's, carpal tunnels, any sort of flexor or extensor tenosynovitis where we can try to rest and mobilize at the same time is quite useful. That works quite well in combination if that person doesn't respond reasonably quickly, then combining that with a cortisone injection and that rehabilitative process, all the while monitoring at what point we need to get that surgeon involved and take that next step. I sort of describe it to people as like the management ladder, and if we check these things off, then we're providing best care.
Yeah, certainly trying non-operative measures and being supported by allied health like yourselves is a first line of treatment for most things that don't need urgent surgery, that's for sure. Are there things that worry you when you see them, that have really worried you and send them straight back to a surgeon or a general practitioner?
I think when we're looking at pain management, how that person is coping with the injury and how that initial response is being managed and how that person psychologically is managing that injury. And that's where we might look at getting even psychology or adjustment to injury and counselling put in place really quickly so that person can just have a bit of that catastrophizing to settle down a little bit more. From a clinical perspective, if we're looking at something where we see there's abnormal amounts of swelling or the pain is very acute, or trigger finger if we've got locking happening, if we've got more significant factors than what we can think we will manage, we'll get someone involved straight away. Because I do believe that getting people through that early intervention and getting things before they become chronic is really important. So I would be saying that, there's that psychological profile, but there's also that immune response profile. Maybe if someone has got underlying conditions, do we have diabetes? Do we have a history of immune issues, cancers, anything like that? Then we start to need to make sure that we're not missing anything. And obviously, if we've got any concerns, things like making sure we're getting the radiology involved. So someone might come to me and they may have come from the trainer on the football field and they go, "I just dislocated." Did it just dislocate? So I want to be making sure that I have not yet got my X-ray vision installed. So I need to make sure I've got radiology behind me. Have we got actual evidence that this is just a dislocation, or do we have a fracture that we're actually dealing with as well? Anything where I see something with, if it's an acute injury, if I see really deep bruising, so it might not be extensive, but you have that really deep purpling bruising coming out within 24 hours. I'm like, that's quite fracture-ish. So I'm really looking at those acute and like very point tender, swollen immediately, deep bruising. I make sure I get that rechecked and scanned, and that quick pathway might be a GP just to say, can we get a referral? If we know someone is down there and I'm really quite worried, I'll just reach out straight away and say, may not always be the most right pathway, but my main thing is getting people the care they need really quickly.
So what you're saying is if anything significant that more than a minor trauma, you're always worried about a fracture being missed.
Even same with infection. Like you can have someone come in but by the time they get to you 24, 48, 72 hours later, if there's a different type of redness that I always say is angry. If we've got any signs, and it could be anything from a cellulitis to someone having a hematoma that created an abscess, or they've had surgery and it's 6 weeks later and something has gone amiss. And if I'm seeing angry signs of infection, I'm not missing a beat on that. I'm making sure that someone is checking that out really quickly because, again, getting control of an infection is really important quickly and not letting it linger.
So make sure we don't miss a fracture or an infection.
And I think part of that is I remember having this was probably more of a pain thing where you've got two cases. One is the football player on field does a fractured middle phalanx, barely skips a beat, straps it up, trying to put some of the magic cold spray on, put some tape on, back on the field, plays the rest of the game. Then you've got the solo violinist about to go into her major concerto season for the year and she slams her finger in the car door as she gets out. Same fracture, completely different psychological management. The anxiety, the stress and everything about a finger being injured for the violinist is completely acutely a different management pathway to the football player who's gone and played another 90 minutes of football with their broken finger.
Yeah.
And just how you manage those expectations can create, the injury is the same, but the pathways of how we get to that endpoint can be quite different.
Yeah. So you've got to assess the whole patient as we do.
Yeah.
Obviously, you can't really manage a patient with one consult. And obviously, you have to assess a patient first, ascertain what their problem is, and coordinate a program for that individual.
Generally speaking, with that first consultation, and often this is what I say to my team of therapists, if things are getting tricky, so if that person has come in, that person needs to leave safe. So that's our first goal. So that first consultation, if there's a fracture, if there's a surgical intervention that's being done, we need to make that person safe to go home. So that will be if you've taken a back slab off, usually there's an expectation we might be putting a splint back on. Have they got the right bandages to keep the dressing safe? Is the person safe? And that's the first goal. So we'll be getting information on the op note from the operating note from the surgeon, or we'll be reviewing the referral that's been coming through. We will then review x-rays. And even though the person might say, it's fractured, you'll often find us seeking the actual x-ray so that we can see exactly where it's fractured, because a mid-shaft metacarpal fracture is very different to a proximal metacarpal fracture and how we manage a distal metacarpal fracture. So we want to ideally be visualizing where a fracture is, what zone a tendon has been lacerated in, to be creating then the pathway for the type of splint we're choosing and the exercises that we're choosing. So typically you would see us, we would be reviewing those documentations, looking at the actual hand and seeing what that hand requires, seeing what the expectations are of the patient and how we match a splint and a rehab program to that person. You would usually go away from that initial consult with some sort of device, if appropriate, and the first 3 to 5 exercises that we want you getting on with, then we would have either weekly or fortnightly appointments depending on the injury.
And obviously every injury depends on how quickly they recover.
Yeah.
A tendonitis would normally take about 3 to 4 months to really settle down.
Yeah.
While a fracture can often, we talk about 4 to 6 weeks depending on location.
Yeah.
Yeah.
And different ways some people will regain their range of motion back at different rates to other people. Some people will have different swelling responses. Like some people you can't push as hard as other people, because if we get the swelling is problematic, then we're just creating more dramas and more problem. How stable the fracture is, and that can be a tricky one on the operation report, because we want to be getting a feel for how stable we think the surgeon has been able to secure that fracture. Do we need to slow that person down, keep things a bit more steady, or have we got great screw fixation, and we can move that pretty much normally from the get-go.
Yeah, excellent.
And the idea would be we're only immobilising what needs to be immobilised. So if we don't have to have a wrist involved, we won't include a wrist. If we don't have to have fingers splinted, we won't be splinting unnecessary joints. We want to be providing the most effective immobilisation as possible so that everything else can be mobilised.
Yeah, and obviously in the days gone by, there used to be plaster of Paris. It never goes off. I've still got plaster of Paris, which I bought 20 years ago, which I still haven't got through because we hardly ever use it.
Still a useful tool. I still, for some conditions, I still pull out the plaster of Paris,
Right.
which is quite interesting. But yes, typically these days we're using the low temperature thermoplastics, which are strong, light, durable, remoldable, which I think is important. We don't, every time a person needs a change made to a splint, we're remolding the old splint and we're trimming it down. So we might start with a wrist splint to the PIPJs down to the 2/3 forearm, but every sort of week we're making it smaller and smaller so that as the injury heals, we're freeing the joints that don't need to be stabilised anymore.
So these are those large sheets of plastic which are heat up in a hot water and then molded to the patient. Perhaps you can show us a few on our little demonstration map here.
So I've got a few classics. So this would be a classic splint that most graduates or university students are learning how to make at university level, called a posi splint or position of safe immobilisation. This would be seen in neuro situations or in ICU where someone has a stroke and we're trying to prevent contracted down hands and fists like this.
So this is for the listeners, a one that's going over the forearm and on the palmar side, what we call the volar side of the hand, and then also incorporating the thumb in it in this particular one.
Yeah, so thumb is included, fingers are slightly and comfortably extended. It's a bit of a workhorse in the OT world for splinting because it's got multiple different applications. Essentially, it is immobilising the DIPs, PIPs, MCPs, wrist, and then similar joints like all the way to the tip of the thumb. And we would, that might be used preventatively to prevent contractures, to prevent deformity, to maintain web spaces, or it may be used if someone has had lots of extensor tendon injuries and we just need to get a bit of stillness and rest. But it's a bit of a workhorse.
And the ideal positioning for the MCPs and the PIPs in that scenario?
In that scenario, we would say about 70-degree flexion at the MCPs, and we like to have our IPs out reasonably straight. And then the thumb is slightly or comfortably positioned in opposition, slight flexion at the MP, probably IP straight, but you're also wanting to balance, especially if someone has tone. So if they've had injury that affects like stroke, a spinal injury, or they've got some sort of neurological situation, if someone's really flexing down, if we put them into the position that we want and don't give any care for what the body's actually doing, you can get pressure injuries under the fingers. So sometimes it's not always a perfect position. You might have some flexion or not quite full wrist extension, but you want that balance between not having a thumb clenched inside a fist and not being able to get hygiene. But we want something sort of comfortable and open so that when that person gradually recovers, we're not having to deal with fixed flexion deformities and things like that.
Excellent.
So then we've got another workhorse in the OT world, which is called a thumb spiker. This is forearm based in this example. And this immobilises the thumb and the wrist. Again, different applications will require different positioning. So if we've got someone who's got a scaphoid fracture, we will be making sure that the fracture is aligned in the right position. If we're looking at more of a wrist issue, then we're changing the positioning of things ever so slightly. But key thing we're looking at is making sure we've got full range of motion, in this instance of the fingers. And in this splint, we can mobilise the IP joint. So someone's got reasonable function, we can actually oppose. We can use that hand quite freely. We're clearing the distal palmar crease. And it's easy to take on and off if that's what we want for the patient to be able to do for hygiene purposes, so that we can take that splint off the shelf. And that as well, the level of independence we give a patient will change at different points through someone's rehabilitation progress. So if someone has a flexor tendon laceration that's been repaired in zone 2, we're managing that hygiene primarily until that tendon is safe enough to be moved.
And so obviously with all these splints, I always tell the patients that they shouldn't really be driving a car because they can't control it safely.
Certainly we have had a few conversations with different people in law enforcement, both lawyers, police officers, detectives. But I definitely say that if you have your thumb in a splint and your wrist in a splint, then that's definitely not driving. It's usually as well, if they're wearing a splint, it's not best for them because I don't want them putting that tension or that load through that joint. And we say there was no point going through all this surgery only then to overload the joint and not let it heal correctly as we need to. And if we've seen them, if that's someone we might have seen conservatively, we'll prep them for that. We'll say you need a window of time leading up to surgery, make sure you've got some people around you that can drive you different places. And that's where I always say as well, we try to have different locations in different aspects of OT so that your rehab is close to home. It's great. Like with your surgeon, you go and see the surgeon that might not be super close to home because you want that person doing that thing, but the touch points post-operatively may not be so high. So you might 2 weeks, 6 weeks. So you make a big drive to go and see your surgeon because that's the person that is doing all the work on the inside. But for rehabilitation, we try and make it close to home. So we try and make it convenient. So yes, smaller little splints that are less occlusive to the hand, we say, and we've checked that that's not so problematic for driving. And then at the right time, if they're safe to do. I always say I like people to have a reasonable grip strength of 10 kilos, even though there's no rule for this. This isn't law. This is just my preferences. I like people to have at least 10 kilos of grip strength so that they've got enough strength on the power steering vehicle to drive. I like them having an auto as well. And I like them to be able to, at home, be able to do a 3-point turn and a reverse parallel park. And once they can achieve that, I say then you can get yourself in and out of the car park. Being able to stop suddenly and stop and avoid an accident, that's where the stress comes in the hand with driving. So that's on top of the general rules. I get a little bit more specific about what I want people to be able to do before they're out driving.
Yeah, I'm very cautious. I feel if a little lad runs out in front of the car with chasing a ball and you haven't got perfect control of that vehicle.
And that's what I say. If I feel like someone is going to be a bit not maybe listen to that so much, I say this is not the time to have a little kid's life on your conscience because you just wanted that shortcut. And I do come down pretty hard on that sometimes. I said one of two things is going to happen. You're going to hurt yourself or you're going to hurt someone else. Just don't do it.
Brilliant. Okay, Charlotte, obviously you provide this treatment and splints, but obviously it's a two-way process. What are your tips for collaborating with, say, surgeons or general practitioners who refer to you?
So ultimately it starts with that referral to an occupational therapy provider, similar to physio. The client might reach out independently. If you're privately paying or using private health insurance, don't technically need someone beyond that process to refer you to our service. So you can self-refer. Otherwise, typically someone goes to see their GP because they have pain and a problem. That GP may organise that referral for you. So typically they write a bit of a letter as to what might have happened, fallen outstretched hand, or they might have had a baby and they've got decor veins. A little bit of information. Please assess, give us your thoughts. So we'll meet that person, give them our thoughts. Sometimes we might say, maybe it's intersection syndrome, not decor veins, and we will try and feed that information back via another letter back, an email, or a phone call. Again, from that surgical pathway is quite similar, but we might be utilising that operative report. And on that operative report, there might just be a sentence like immobilised for 6 weeks in a splint, take down bandages, sutures out at 10 days, or a little bit of information just usually at the bottom of the op note. Referral can just be name, detail, phone number, and particularly if we're then reaching out to that patient. And in terms of communication back, we try to find out what suits the person that's referring. Generally with GPs, we're bouncing back with another letter that we're trying to get through quickly and efficiently. Most injuries have a very basic recipe book that we as beginner therapists learn. So we know like distal radius fracture is a splint for so many weeks, and at this week we do X, and at week 4 we do a bit more, and we try to progress. But we learn what particular surgeons also like. You've done your suspension arthroplasty and you've got the mini tightrope in as well, and how do you like to manage that versus if there's K-wires? And we grow our particular protocols, and we use our Track Active program, and we'll have Dr. Nyman's distal radius program that we like doing, or even if it's things like we try to have that information recorded so that the therapist can pick that information up, see what protocol someone likes to do, and see how we move things along from there. So it's quite collaborative at that post-surgical level because everyone has developed their own slightly unique approach to managing these conditions, and we like to match our rehab protocols to suit what's happened surgically. When we're looking at conservatively managed, again, there's protocols, there's recommendations, but we're also trying to match that with a person themselves. And we try to communicate what we're doing back as regularly as we can.
Brilliant. On that process of the work cover, there's all these different scores and patient-related outcome measures and things that they're often are done as part of the assessment for a work cover type injury or motor vehicle accident. What's the process? Are they demanded by legislation in Australia, or are they things that just help your recovery? Or
they're not so demanded. They're useful tools to try and quantify a qualitative process is the way I describe them. Sometimes the quick dash or the dash is a classic, and they're used as indicators. From a work cover perspective, I think they're trying to see those red flags as to how is someone's pain tracking and how is this going? Are we going to have issues returning to work? So sometimes they're used in that predictive sense. Otherwise, they're just used to track how well that person feels they're going with their injury. And we do them we don't do them all the time. But in our space, in the hand therapy space, we're really seeing what gives that person information. We usually range of motion and grip strength are our big ones that we would use regularly as our reliable factors. And patients love it. They can see their movements happening, or they come in a week later and go, I haven't really improved, but I've been doing everything. And I can say, no, you actually improved 6 degrees. That's fantastic. So it's quite motivating. They love seeing their strength go up. That's fantastic. Using the questionnaires, we might send that home as an email, and then it builds information in a report. We can say, hey, this person's tracking really well. Or if we're seeing those pain factors hanging around, we can say this person's a bit stagnant. We need to put some more intervention in place, maybe some adjustment to injury counselling, maybe some physio. Even at that transition point, looking at getting an EP, an exercise physiologist involved is really useful. So they're not be-all and end-all measures, like they're useful
as a guide.
Guides to information as to what's going on and how we're tracking with progress.
Excellent. And what about edema? I believe getting movement helps get the swelling out.
Yeah.
I know traditionally they've talked about using Coburn wrapping to try and get swelling out to help the movement. I presume it's a bit of both.
It's picking the right modality for the right base. Generally, if we're making a splint, we use the tubey grip for a few different things. The plastic itself is quite hot when it comes out of a pan. So if we're moulding someone, we generally have a light tubey grip on place just to protect the skin. It's not that hot, but you just need to protect someone. I don't like tubey grip too tight. One of my biggest things is when you see it leaving marks on the skin, it's too tight.
Yeah.
A light bit of compression with tubey grip, getting it moving, getting it elevated. I'm a big one with elevation for making sure that your elbow is straight. A lot of people just have their hand elevated with the kink in the elbow still, and I feel it slows the lymphatic system being able to drain. I like getting people draining the fluid back to the shoulder and moving the hand to pump the swelling out of the hand. That's probably my go-to initially, so long as nothing is too crazy. And ice is another great one. So acutely, post-operatively, people always say, do you use heat or do you use ice? So they're different tools. They're different things. I like acute swelling, so 24 to even a week after an injury or surgery, ice is your best friend. We want that vasoconstriction. We want that pumping away from the peripheral back to into that lymphatic system. So movement, a light cover of tubey grip maybe to just help support the lymphatic system a little bit. I was taught when I did a fair bit of work with lymphedema that if you're leaving white marks on the skin, you're compressing your lymphatic system. So you can't be too tight. When we start to bring Coburn and handy gauze into the situation, we're looking at more entrenched and worrying edema. Someone has had a distal radius fracture, so they've had a fall with some force or some velocity, and the whole hand has puffed up, and we've got that swollen look to the hand, and the movement is restricted because the hand is so swollen they can't move. Then we have to activate things a little bit more intensely. And my go-to with that style of swelling is actually handy gauze, which is a softer white wrap that goes on the fingers. And then I might use Coban on the hand. Again, it's about the tension. So I say I'm opening the weave of the bandage. It can stretch up to 70% of its length. So you don't want it on that tight. Then what happens is, as their movement is so restricted from the swelling, this little bit of movement that they do have, the uneven surface of the bandaging and the spiral nature you've applied it on actually helps that lymphatic system to pump and get that fluid away. So if we're wrapping fingers, there's a very specific reason as to why we're doing that. And again, in most instances, tubie grip is not too tight, is supportive for the situation, comfort for the patient wearing a splint, and is supposed to be working with you and not getting tourniquet off and creating those big divots. So, yeah, but then the wrapping things that we do are very specific. So I had a lady the other day, she crushed her back of her hand, massive hematoma. Like it's like you could hold the hematoma, but then the entire hand puffed up. So that was an instance where we're using this wrapping technique and mobilizing the hand a lot, and even using little devices to create an uneven surface to stimulate the lymphatic system. So that's different types of interventions for different types of situations.
Brilliant. Yeah, certainly there's always a importance to get the swelling out and get the movement back. The other thing too that patients may not understand is the importance of desensitization as well, and particularly after surgery, but after any injury.
Yeah.
And perhaps you can explain that and what your role is in that scenario.
So that's where you may have had someone who's, again, had a trauma and their nerve has had some sort of injury to itself, whether it's been bruised, lacerated, or even just the little post-operative bit of numbness that they get. And we start to get people giving some gentle feedback to those nerves that are, I always say, they've gone out on strike, and you have to grade how you get that nerve to respond again. If you go and give it too much feedback, too much scratchy material, tapping too soon, you can actually create more pain because it seems to disrupt the nervous system too much. Right. So we start with graded desensitization. Maybe we'll use the soft side of the Velcro, just gentle touching. Giving the nerve feedback constantly gives it a reason to come back, is the way I explain it. If you don't give the nerve any input, it's what we don't use, we don't need. So the body tends to not focus on trying to recover that sensation. Yeah. But if we give it graded input, as it can tolerate it, if some people they become very hypersensitive and they can't tolerate anything on there, and if you push them too hard, you'll just make the patient feel sick. They'll start sweating. It's a really visceral response. You can see that they get to it. But so we grade it. We use soft textures, light textures. We'll start distal to the lesion and slowly work up so that we can really find where the problem is and just psychologically help that person through getting that sensation back and getting used to building up to things like tapping, rougher textures, different inputs and stimulations.
On the other side of the coin, where the nerve is hypersensitive, gentle touching can help desensitize.
Yeah. So it's about just finding the right point. So sometimes you'll see the little mini massages that provide vibration stimulation. That can be, if you put that in too soon, that can really upset someone. So it's just about finding the different point at which you introduce all these different things. You need the stimulation, you need to settle it down, and you just need to find the right type of input for that nerve to help. And it can be finding that point at which they really there's usually almost a clear line you can draw around the boundary between what feels good and what doesn't. And up to a certain point, you'll use one type of stimulus, but then over that area, you'll use another type of stimulus. Sometimes this can be good and bad, and you've got to really understand how your patient's mind is ticking. We can put like a towel over where the injury is to dull the sensation slightly so that they're still touching it, but they're getting some stimulation back. So it's just about trying to find different ways of helping that person. Sometimes we say to a person, put a light bracelet on, and that bracelet just helps constantly give a bit more feedback, or some people can't tolerate that. So it's just about finding those different little ways to constantly get little bits of stimulation back into it so that we don't create an entrenched hypersensitivity pattern where they don't use the hand. That's the big thing we want to avoid.
Brilliant. So, Charlotte, obviously you're quite passionate about providing good care and for these patients. Are there any barriers you come across that might affect recovery? And is it important to really have a patient who's engaged in their own process as well?
Yes. So I'd say one of my biggest barriers is if we have late referral or an injury's been put to the back burner for a few months. I always say it's almost like the longer an injury has been present for, that amount of time is what it's going to take to recover from. So if we've been ignoring tennis elbow for 12 months and now it's raging and it's really unhappy and can't even think about it, we've got a longer journey ahead of us for that recovery time frame. Similarly, if we've had a boutonniere deformity and we've played the whole season and thought it would just get better, and then 9 months later we've got a nice little 45-degree plus a fixed flexion deformity, we're going to be battling for a while to get those, to recover from those sorts of things. So that's where we do, and that engagement in rehab and finding what that person does. Do they use a computer for a living? And if I make a few adjustments to their computer setup and get their finger moving on the top keyboard, are they an keen knitter? And I need to know, how do I include those things into their rehab program, as opposed to being told to do these little weird hand therapy exercises 16 times a day or whatever. I try to utilize the aspects of their life that are naturally therapeutic or rehabilitative into their program, or I tie things in with the day. So pop this theraputty next to the kettle. Whilst you're waiting for the kettle, we're going to do some putty squeezes, so that we're trying to tag our intervention to fixtures that are already in their day, and we're just asking like one little thing on top of that, so that we're not creating a huge, extensive programs, complicated programs that can be quite difficult for a patient to engage in. So I like to use what their natural things of hobbies and enjoyment are, or I make things very specific. So how can someone wants to get back to lawn bowls? Maybe we need a bit of an adaptive equipment. You can get different little things to help bowl. So the person is still doing the thing they love, but they're able to now wear the splint that I want them to wear because they've had a fracture or something. And we're combining the two things. I'm getting my rehabilitation. They're still participating in their thing that they love doing. We take the same approach with work. What small aspect of work can be done? Can it be done in a different environment? Can we take that? Can someone do something from home? Can we adapt the ergonomics to make sure someone is engaged and happy and feeling useful? And I think that really helps people's rehab. I try to not over-medicalise things too much. And yep, you're there with them on the journey, but they're in control of how well their outcome is at the end of the day. And we make sure they don't feel lost along that pathway.
Oh, brilliant.
So that's how we'd approach that side of things, I think.
On that basis, are there new technologies or advances in the whole system that makes people both more engaged but also helps the rehab as well?
I think we're on the cusp of a few amazing things. I'm watching all the spaces as best I can. I do love little interactive apps on phones that can just gamify exercises. So we've got a few grip strength things that make a little action person move along a screen, make it a game, but they don't realise that they're actually doing their rehab at the same time. If that is what we think is going to engage that person, then we'll do it. If we have different games that we can play with someone that is more engaging, that's fantastic. In terms of the technology, I think we will see at some point 3D printing become part of our toolkit. At the moment, it's not quite there. It just takes too long to printing a splint of this size. The time frame would just be too long. They're not remoldable. They're still a bit rough, but I think we're going to get there. There's some really cool stuff happening in the Netherlands where they'll scan an image of your hand. It then goes to the Netherlands. This amazing, cool-looking, pearlescent, futuristic-looking splint is then created and sent back. That's really great for things that are needed long-term. So if someone has a bit of arthritis, adamant they're not having surgery, and we can create something like that's becoming more available. It's not quite available here as freely yet, and the splint isn't quite as cool or up there yet on top of what we've got available here in Australia. So I haven't gone down that path personally myself yet, but I think it's getting really close, which is great. And then looking at different things. Virtual reality, I think, has got huge impact in returning to your work or tasks a lot quicker, because suddenly you can be immersed in a world where you're doing the work thing. And I've seen these situations, they're filming like in real life. It's not a gamified cartoon environment. It's real, and you're walking down the street and your hand is there functioning beautifully and normally in the vision. You might have a very injured hand in real life, but it's doing the things that you want your hand to be doing in real life. So I think in terms of a lot of pain management, a lot of getting people's brain recognizing that their hand can do things sooner with the use of VR is going to become really exciting in that space. And I think that will have a huge benefit to adjustment to injury, to adjustment to even in our prosthetics group where people have had amputations. That I think is going to be amazing to research as well.
Brilliant. Sounds exciting times. So what advice would you give to the young medical student or young GP coming through the process about occupational therapy and hand therapy in particular?
I think it would be really interesting for someone who's learning that medical space, once you're feeling like you've heading into a path that you like, if you can see a speciality you're heading towards, try to get to spend a day in the life at the end of that rehab process as much as you may be at the beginning of that process, so that you're really creating that sort of 360 view of how that injury process looks to that person. I think we can get a bit stuck at our either end. Similarly, I tell my students and my young therapists to go and attend as many surgeries as possible, so that they're seeing, because we see the end. Yeah. We see them all wrapped up, neatly stitched up and looking beautiful. I said, go and see what's happened. And then you'll understand the trauma. You'll understand why your PIP joint is so swollen afterwards, because you're going to see what it's gone through. It's been through a lot. Similarly, I'd say to that new surgeon, that GP, that person, try and spend a day, half a day, whatever time you've got. No time is precious. Understanding what we're dealing with at our end and how we're engaging that person, the pain that we might be experiencing at 6 weeks, which they don't write about in the textbooks and that isn't the common sort of standard and process. If you can see what it's like at the other end and how that person is going 6 weeks later and what we're putting them through and what we're trying to achieve with, I think sometimes splints are seen as just things that keep things still. And we love people understanding that, no, this is helping us mobilize. I know it's a rigid piece of plastic, but we're doing this amazing stuff with this rigid piece of plastic. And as much as not splinting, yes, they're going to move their hand more, but we're trying to overcome a few deficits at the same time. So seeing what we can do and the creativeness with which we're trying to get people moving and functioning would be really amazing. Even if someone's in a more medical space as opposed to surgical, seeing what's happening when that OT is trying to get that person home. What are we trying to achieve with medications? Like I had a few things where someone's got dementia, but they've suddenly been given medication to take 6 times a day. And how are we making that happen? Because there's some huge, big functional things that we've got to get through there, and how we support that person through that process. So on both ends of that spectrum, I think remember that it's this part of care is linked to this part of care over here, and trying to approach it from both ends to really understand that process.
Brilliant. It's been fantastic having you come on Aussie Med Ed today.
Thank you for inviting us along.
It's been great. So sharing your expertise and shedding light on both occupational and hand therapy, your insights and patient-centred rehab and collaborative practice are really useful. To our listeners, thanks for joining us, and hopefully this podcast today will shed more light on another area of important part of rehab for a patient under your care. Thanks very much.
Thank you.
Thanks again for listening to the podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. I'd like to let you know that Aussie Med Ed is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely, and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.